This recorded lecture goes over Chapter 31, The Child with a Metabolic Condition. Integration of the nervous and endocrine systems. Figure 31.1 on page 720 depicts the organs of the endocrine system and outlines how this system will differ in children than from that in adults. Hormonal control is more immature until at least 18 months of age, so infants are more prone to problems related to the functioning of the endocrine system. Lethargy, poor feeding, failure to thrive, vomiting, and an enlarged liver could be early signs of an inborn error of metabolism in the newborn. Unexplained mental retardation, developmental delay, convulsions, and odor from the body or from the urine, or episodes of vomiting could be subtle signs of a metabolic dysfunction. Tay-Sachs disease involves a deficiency of lysosomal beta-hexosaminidase, an enzyme that is necessary for the metabolism of fats. The infant with Tay-Sachs disease is normal until about age 5 to 6 months, when physical development begins to slow. Most children with Tay-Sachs disease die before 5 years of age from secondary infection or malnutrition. There is no treatment for this devastating disease. Hypothyroidism occurs when there is a deficiency in the secretions of the thyroid gland. It can be congenital or acquired. It is one of the more common disorders of the endocrine system in children. The older child will acquire juvenile hypothyroidism. Mental retardation and neurological complications are not seen in the older child. The infant with hyperthyroidism is very sluggish and sleeps a lot. The infant will feel floppy when handled due to hypotonia. If hypothyroidism is left untreated, irreversible mental retardation and physical disabilities will result. Early recognition and diagnosis are essential to prevent the developing sequelae. Treatment will involve the administration of the synthetic hormone called levothyroxine sodium. Children may experience reversible hair loss, insomnia, and aggressiveness, and their schoolwork may decline during the first few months of therapy. This is temporary. Hormone replacement for hypothyroidism is lifelong. Diabetes insipidus can be hereditary or acquired as the result of a head injury or tumor. Polydipsia and polyuria are the initial signs. Loss of weight, growth failure, and dehydration will occur rapidly. Treatment involves hormonal replacement of vasopressin in the form of desmopressin by subcutaneous injection or orally, or DDAVP nasal spray. A medical identification bracelet should be worn. School personnel should be advised of the child's needs. Home care instruction should include recognizing the signs of water intoxication, dehydration, and hyponatremia. On page 722 within Table 31.1, you can read about some common metabolic dysfunctions. Diabetes mellitus is a chronic metabolic syndrome in which the body is unable to use carbohydrates properly, leading to an impairment of glucose transport. DM affects the physical and psychological growth and development of children because it requires lifestyle alterations. Treatment will be designed to optimize growth and development and to minimize complications. Type 1 diabetes is the most common metabolic disorder of children. Type 1 diabetes mellitus is an autoimmune condition that occurs when a child with a genetic predisposition is exposed to an environmental factor. On page 723 within Table 31.2, you can see the different classifications of diabetes mellitus. Table 31.3 on page 723 will list the clinical features of types 1 and type 2 diabetes. Symptoms of type 1 DM may occur at any time in childhood, but the rate of occurrence of new cases is highest among 5 and 7-year-old children and pubescent children 11 to 13 years of age. The disease is more difficult to manage in childhood because the patients are growing, they expend a great deal of energy, have varying nutritional needs, and face a lifetime of diabetic management. The initial diagnosis may be determined when the child develops ketoacidosis. Children with diabetes mellitus will present with a classic triad of symptoms: polydipsia, polyuria, and polyphagia. These symptoms will appear more rapidly in children. There may be a history of recurrent infections. Glycosuria and hyperglycemia will be evident in lab tests. When type 1 is initially diagnosed and the child is stabilized by insulin dosage, the condition may appear to improve. This honeymoon period will last a short time, and parents must be encouraged to closely monitor blood glucose levels to prevent any further complications. A non-fasting blood glucose over 200 milligrams per deciliter and classic symptoms are diagnostic of diabetes mellitus. If a person's fasting blood glucose level is greater than 126 milligrams per deciliter on 2 separate occasions, and the history is positive, the patient is then considered to have diabetes mellitus and will require treatment. Other diagnostic tests that can be used to test for diabetes include a fasting blood glucose, a glucose tolerance test, and a glycosated hemoglobin test. An oral glucose tolerance test is not recommended for children because the results are not as reliable as in adults. For a hemoglobin A1C, values of 6.5 to 7.5 can indicate impaired glycemic control. Diabetic ketoacidosis can also be referred to as a diabetic coma, although a person may have DKA with or without being in a coma. It is manifested by ketonemia and may be precipitated by a secondary infection. This happens fairly often in children with diabetes. Symptoms of ketoacidosis can be compared with those of hypoglycemia in Table 31.4 on page 725. The symptoms will range from mild to severe and could occur within hours to days. The 3 goals of treatment in type 1 diabetes include ensuring normal growth and development through metabolic control, enabling the child to cope with a chronic illness, have a happy and active childhood, and be well integrated into the family, as well as preventing any further complications. A planned educational program will be necessary to provide a consistent body of information, which can then be individualized. Infants and toddlers may have hydration problems, especially during illness. Preschool children will have irregular activity and eating patterns. School-age children may grieve over the diagnosis and ask, "Why me?" The onset of puberty may require insulin adjustments as a result of growth and the antagonistic effect of sex hormones on insulin. Children must assume responsibility for their own care gradually and with a minimum of pressure. Nursing Care Plan 31.1 on page 726 will list different interventions for the child with diabetes. All of the information should be provided gradually and at the level of understanding of the child and family. Home glucose monitoring should be taught to all young patients and their caregivers. Cost, convenience, and portability will be factors to consider whenever selecting glucometers. A continuous glucose monitoring system could be used by children aged 7 years or older, and it has been in use for several years. Different methods of insulin administration can be seen on page 728 and 729. A closed-loop system does not completely eliminate the need for blood glucose monitoring checks, which should typically be done before meals to determine the need for a bolus injection based on the food intake of the meal. This combined technology could be used for children over 7 years of age who require a minimum of 8 units of insulin per day. It is important to teach parents and the child about the administration of insulin. A child could be taught to perform self-injection after 7 years of age. The young child and parents can use a doll or simulator to practice these self-injections. The various types of insulin and their actions are listed in Table 31.5 on page 729. The child should be taught to feel for lumps every week to avoid using any sites that are suspicious for lipoatrophy. Insulin shock, also known as hypoglycemia, will occur when the blood glucose level becomes abnormally low. Children are more prone to insulin reactions than adults because the condition itself is just more unstable in young people. Children are continuously growing, and their activities are typically more irregular. Poorly planned exercise is often the cause of insulin shock during childhood. The child may become irritable, behave poorly, appear pale, and may complain of feeling hungry and weak. Sweating will occur. The child may become mentally confused and giddy, and muscular coordination will be affected. The immediate treatment will consist of administering sugar in some form. Glucagon can be recommended for the treatment of severe hypoglycemia. The Somogyi phenomenon occurs when blood glucose levels are lowered to a point at which the body's counter-regulatory hormones are released. The child may awaken at night or have frequent nightmares. The dawn phenomenon differs from the Somogyi phenomenon, in which early morning elevations of blood glucose will occur in the absence of preceding hypoglycemia, and this may be a response to growth hormone secretions that occur in the early morning hours. Together, the Somogyi and dawn phenomena are the most common causes of instability in diabetic children. The triad of diabetes management consists of a well-balanced diet, precise insulin administration, and regular exercise. The nutritional needs of diabetic children are essentially no different from those of non-diabetic children. The goals of nutrition management in children are to ensure normal growth and development, to distribute food intake so that it aids metabolic control, and to individualize the diet in accordance with the child's ethnic background, age, gender, weight, activity, family economics, and food preferences. Special supplements may be required to accommodate the exercise patterns and growth needs of children. Carbohydrate counting can provide flexibility in meal planning. Education of the patient should be ongoing. Too much information given at one time could overwhelm the parents and discourage the child. Children should be encouraged to bring their lunches to school. In the diabetic patient, soluble fiber has been shown to reduce blood glucose levels, lower serum cholesterol values, and sometimes reduce insulin requirements. The glycemic index for selected foods has an impact on the manipulation of dietary needs. You can read about the glycemic index of some foods within Table 31.6 on page 732. The blood glucose level will be high immediately after meals, and this is when the child should participate in active sports. The diabetic child should be able to participate in almost all active sports. Adolescents should be taught to use electric razors. Although circulatory problems of the feet are less common in children, proper habits of foot hygiene should still be established. Immunizations against communicable diseases are essential. On page 733, Table 31.7 lists nursing interventions for stress on the child and family related to type 1 diabetes. When urine checks are advocated for the patient, you should say urine check rather than test. This can be less confusing to the young child. The patient should be taught to recognize the signs of insulin shock and ketoacidosis. Teachers, athletic coaches, and guidance personnel should all be informed about the disease and should have telephone numbers of the patient's parents and healthcare provider. The child should see their healthcare provider regularly. When illness occurs, close glucose monitoring and control are essential. Diabetic retinopathy, the leading cause of blindness in the United States. The risk is 91% for type 1 diabetic children and 78% for type 2 diabetic children. Nephropathy affects 20 to 30% of diabetic children. Adolescents should be assessed for peripheral neuropathy. Type 2 diabetes mellitus occurs in 1.45 out of 1,000 people within the United States. This is more prevalent in children and young adults. Twins are more often at risk for type 2 diabetes mellitus due to intrauterine growth restriction, as are infants born with a low birth weight who will gain weight rapidly during the first few months of life. Many adolescents will remain asymptomatic for years because the hyperglycemia is moderate and signs and symptoms are not dramatic. The American Diabetes Association recommends that all adolescents who are overweight and have at least 2 risk factors for diabetes mellitus be screened by a hemoglobin A1C test every 2 years after puberty. Treatment guidelines for type 2 diabetes mellitus include lifestyle changes to reduce obesity and anti-diabetic medication, such as metformin, which is the only oral anti-diabetic agent that is approved for children and adolescents.